Hi, I'm Dr. Jennifer V. Brown, your stroke specialist. I'm aging gracefully with stroke due to sickle cell disease. And today we're going to discuss some exercises and physical activities to reduce knee hyperextension after stroke. So let me just define hyperextension for you. It's when the ground reaction force, it's a line that goes up to your body to balance your muscle activity in front and in back of the line. But in this case, the line passes anterior to the knee joint, resulting in more extension beyond 0 degrees. You usually have greater than 5 degrees of hyperextension because this line passes anterior to the knee joint. So it comes right in front of the ankle and it should go right behind the knee joint, but it comes in front of it. And also it passes through the hip joint in front of it, causing the trunk to be forward, and the trunk moves with the pelvis. So when the trunk moves forward with the pelvis tilts forward, it causes weakness of the gluteus maximus and the proximal hamstring. When it tilts forward, it has to pull from someplace. Remember, your hamstrings are attached to the tibial plateau of the leg, thus often pulling the tibia backwards on the knee. So the key intervention for knee hyperextension is proprioceptive training. It's active movement, passive movement, balance training, somatosensory stimulation like jumping, vibration, discrimination training. Do you know if your knee is bent or straight? And then we combine all of these things together as proprioceptive interventions. The key is, can you keep the knee bent? And the focus is on the quads to train them eccentrically. But when you train the quads, other things are kicking in too, like your gluteus maximus, your buttock muscle, your proximal hamstring, and your calf muscles. In the research, an activity is prowling is prevalent. You're walking with both of the knees in flexion with the trunk in a mild forward flexion. Remember, the gluteus maximus controls the pelvis and the trunk forward movement and lifting it back up. So if you have it too far forward, that eccentric work of the gluteus maximus, it fails. It's so weak. And so you keep it a little bit upright. So mild forward flexion. But I do some other things in addition to the prowling. I do single limb stance, and I'm trying to keep the knee at 0 to 5 degrees of flexion. I do partial squats with the feet and the knees even. I do single limb partial dynamic squats, which is very difficult. They have to lower the hemiplegic leg and then bring it back up. It's very difficult to do. And the less affected leg is non weight bearing. So they're literally on one leg, that weaker leg. And then I do a lot of carryover with the walking with the knees bent that you usually see in daily activities. Like I have people sidestep and open up all the bottom cabinets, and then they have to go back and close all of them. Or they walk with a weighted laundry basket with wet and dry clothes. It's a difference in a squatted position. When you do the prowling, the research shows it has a short term effect on knee hyperextension and gait speed. So you may have to do some other things. Sometimes I add a sleeve, like a knee brace for swelling, because that compression, that proprioceptive input, often controls the knee. So let's look at some video. I had her at the counter with her knees bent at the counter, and she had to stay in that position and hold it while she moved her arms back and forth on the countertop and then lift things of different weights up and down from the countertop. This gentleman has to move his legs rapidly forward and backwards without hyperextending with the foot placement backwards. And for this person, I have them walk, all right, and then they have to squat and then continue and hold the squat position whilst the opposite leg moves forwards and backwards. And then I have them just hold that position and continue walking that position. So I isolated the squatting position in the hemi lower extremity. So these are some clinical questions to ask. Is there adequate range of motion at the hip, knee, and ankle for flexion and dorsiflexion? And that dorsiflexion is at the ankle. Moreover, is there adequate eccentric strength to maintain an upright trunk with hip flexion? And you got to think about the eccentric work of the gluteus maximus, proximal hamstring that attaches to the pelvis. And then the knee flexion, I'm focused on the quadriceps. And then ankle dorsiflexion, I'm focused on the posterior tibialis and the gastrocsoleus complex. Gait is highly eccentric, but we don't do enough eccentric exercises. And again, there may be a lot of reasons why the knee hyperextension is occurring. And so you have to focus the intervention on the problem that's causing the knee hyperextension. The assessment of knee hyperextension, more to come on that. Remember, I am your trusted source for all things ankle foot orthoses and stroke neurorehabilitation. Scan the QR code and go to my website. Send me an email. If you are interested in getting my book on what to examine for an ankle foot orthosis, which is usually given to prevent knee hyperextension, it doesn't always fix the problem. You may learn a few things. This book was written for individuals with stroke, but I have a whole chapter dedicated to physical therapists and orthotists, as well as the chapters for what the stroke survivor should be asking the physical therapist and the orthotist. The book is on sale. Email me so you can get the amount and a deal. Remember, the references are so important for providing evidence-based care to our clients to improve their outcomes. Thank you for listening to this video. Bye. See you next time.